Um, and so without further ado, I'm going to get started. This is our introduction to cancer and radiotherapy. Um, Today, we're going to make sure everyone's on the same base before we begin this learning journey. What is cancer? How is it treated? And then I want to share the pearls that I think are most relevant for RTTs for the physics of radiation treatment and the radiobiology of radiation treatment. And I think I can teach you the most important things that you need to know in 1 hour. It's a big topic, but at the end of the day, there's only a few things that you really need to have a good understanding about to master your role as an RTT. So what is cancer and how is it treated? Cancer is accumulation of cells. And as you can see here, on the left side, we have normal cells and we have cancer cells. So the difference is that cancer cells grow more rapidly. They populate and form large masses called tumors. And it takes many, many cells, actually 10 to the 9 cells, before you can see a tumor that's 1 centimeter in size. So when there's cancer, there's a risk that there could be microscopic disease. Even if it's just 1 cell, you wouldn't be able to see it on a CT scan. And that's why a lot of our treatment, we're treating areas where we don't see any disease, but where we suspect there could be microscopic disease. There's a difference between cancer and tumor, though, because a tumor is a lump of tissue, and not all tumors are cancer. Some tumors are benign. Benign tumors do not invade other nearby structures. They don't have this potential to spread around to other parts of the body and metastasize. Whereas cancer is malignant. A tumor that's malignant is cancer. And this is a disease that can start almost anywhere in the body. They grow together and they have the capacity to grow and spread in uncontrolled and unorganized ways. So how do we treat this? There are 4 pillars to cancer treatment: radiotherapy, chemotherapy, surgery, and more recently, immunotherapy. These all have their different strengths and their different roles. Of course, we're the coolest with radiotherapy. And with radiation, we're used mainly 2 different ways for treating cancer. One is to try to cure cancer. We want to destroy any visible tumors. Often we're used in combination with surgery for a cure. If we give radiation before surgery, we call this neoadjuvant radiation. If we give radiation after surgery, we call this adjuvant radiation. And either way, we reduce the risk of recurrence microscopically. Or in some patients, we're not trying to cure the cancer, but we're trying to reduce symptoms. Think of a patient with large metastatic disease. We're not treating all of the places where there's cancer. We're just treating the spots where they're at risk of having symptoms or they're already experiencing bad symptoms. In this case, we're trying to shrink the tumor that's disrupting their quality of life. And we alleviate pain by reducing the size of the tumor and inhibiting its growth. The radiation is often combined with chemotherapy and surgery to cure cancers. For radiation, there are 2 ways that we can deliver it. One is external beam radiation, which I think most are familiar with. And for centers that have brachytherapy afterloader units, we can give internal radiation. Here's a video showing the insertion of a catheter and then the application of a source to hit this tumor that is near the rectum, and brachytherapy delivers radiation from the inside out in order to target areas that are easy to access or in locations where we really need a sharp dose fall off.
Sorry, we have a question.
Oh, sure.
Moan Kirill, he asked him, how about the interventional radiology? Is it part of cancer treatment?
Absolutely. So interventional radiology can help with certain procedures. Some is chemoembolization, there's cryoablation, there's thermal ablation. So these are techniques that are used to treat certain kinds of cancers. We won't go into this for now, but oftentimes we'll be working as a multidisciplinary team, considering all of the treatment options. And so what's happening when we are treating cancer with radiation? I'd like to show a quick image, because the image says 1,000 words, but this is an example of a prostate gland with a tumor. And as you can see, the tumor is composed of cells that are rapidly dividing. So this is malignant. And as we zoom in to the tumor, we see the organelles, and now we're getting into the nucleus. And inside the nucleus, there's DNA, which is the instructions for our cell to grow and divide. Radiation causes damage to the DNA, and the DNA damage then makes it hard for the cells to divide, and it makes the cell die by apoptosis or necrosis and shrinks the tumor. And you can see that external beam radiation was used with MLCs and IMRT technique to help make sure that the radiation that we gave was optimized, was focused on the tumor, and spared the organs at risk. External beam radiation can be used to treat anywhere on the body, and it can be designed in many ways depending on the available technology. Brachytherapy is typically used to treat places that are easy to reach. So for gynecologic cancer, breast cancer, prostate cancer, skin cancer, or eye cancer. And if you get given with low dose rate or high dose rate needle implants, known as LDR or HDR. And there's three main things that we need to consider if we want to cure cancer with radiation. One is we have to give adequate dose. Two, we must cover the entire tumor volume. And three, we have to consider the normal tissue tolerance. What can the tissues handle, and how can we reduce complication rates? There's something called the therapeutic ratio, which I think is one of the most important concepts, because we want to think, how can we keep a low probability of normal tissue complications while achieving high probability of tumor control? And I want you to think about this for a second. If on the x-axis, I have our dose, and on the y-axis, we have the chance for control. Is there any kind of cancer that we could not control? If I gave enough dose, could I kill anything? And the answer is, if you give enough dose, eventually you will control everything. But once you get to a certain point, the extra dose you add is adding maybe not as much. So, if I kept drawing this line for like a mile, eventually I might get down. If you give enough dose, you can destroy anything. So why is it that we sometimes struggle to cure cancer? Well, The thing is, we have other parts in our body, and we can't just give a million gray treatments, or else will kill the patient. So we need to balance this with our normal tissues. And so there's a separate line here that is damage. Okay. And so blue is my normal tissues, and they can tolerate a certain amount of dose, but once it gets to a certain point, we start to feel damage. And in the same way that as you increase the dose, you increase the damage. So we don't want to destroy our organs when we give radiation. So there's a sweet spot here where we can get a high chance of control and a low chance of damage. And this difference is called the therapeutic ratio. Okay.
I have a
And
question from someone. They
sure.
said, are benign tumors, or do benign tumors need surgery?
It depends. If in general, if there's a benign tumor that's small and it's not causing symptoms, sometimes it can be observed. Sometimes the risks of surgery outweigh the benefits of removing it. But if it's a benign tumor that's in a bad spot, or if it's causing problems, then they'll often consider surgery to remove it. Or if it's in a hard place to access a surgery, they may consider radiation alone. So it depends on the histology, the location, the size, and the symptoms. Great question, though. And so with therapeutic ratio, I've talked about the first curve, which is chance of curing cancer, and the second curve, which is the chance of normal tissue complications. So which of these two looks better? Well, I would want the one that has a higher chance of controlling the tumor. So this one is okay, but this one is better. And to get better, this is where IMRT comes in, because we can deliver higher doses with conformality and dose fall off that helps spare the normal tissues. And so we can get a better therapeutic ratio and more optimally treat the tumor while sparing the normal tissues. So we're going to get into the physics of radiation treatment now. We'll talk about particles and radiotherapy, the impact of energy, interactions of radiation with matter, and how we apply these concepts in clinic. This is important, so I want you to pay attention. Starting with particles and radiotherapy and the impact of energy. Some of you may have seen this picture before, but there are different kinds of particles that are used in radiation. There's electrons, there's X-rays, alpha rays, neutrons, protons, and the different kinds of radiation have different penetrations. And so you can see there's different layers of material, and some, even a thin layer is enough to stop the particle. And for others, like X-rays, they'll pass through many things. And some pass through almost everything. How they deposit the dose is also different. For radiation treatment, maybe 99% of the cases, we're talking about electrons or beta rays, or we're talking about X-rays or gamma rays. High energy ionizing radiation causes DNA damage. We saw in that video how DNA damage leads to the eventual death and shrinkage of a tumor. And there are two types of ionizing radiation. There's radiation with charged particles, either electrons or protons. They cause direct ionization. This means the cell is damaged directly by the charged particles that we're shooting. Or we can shoot with photons, which are uncharged particles, and these cause indirect ionizations. Those photons that we shoot through don't directly damage the cell, but they interact with other materials and molecules as they travel, which then produces new charged particles, in this case, energized electrons, that then damage the cells. So this is a key point. We want to think that we have a charged particle that is going to interact with the DNA. So if we're not shooting a charged particle, if we're shooting a photon, when that gets close to the DNA, it's going to interact often with water molecules, which will then produce charged particles, which will then interact with the DNA. So ultimately, DNA damage is occurring from these charged particles or electrons. How far deep into the body the dose is delivered and where damage occurs is called the penetration depth. So here's a ruler sort of illustrating depth. And if I were to aim a beam and count how many charged particles I'm depositing along its path, it would look something like this, and I would start to get a curve. And maybe in the beginning, I have some charged particles, and then as it gets a little deeper in, the charged particles increases, and then it begins to decrease and plateau.
Mark Sagua asks,
Mhm.
Can therapeutic ratio and therapeutic window be used interchangeably?
It's a good question. I think that those are different terms. I can double check, but I believe therapeutic window is a range at which we're giving a treatment that is effective, whereas therapeutic ratio is the difference between the tumor control probability and the normal tissue complication. But I'll double check that for you.
Thank you.
So now translating this idea of penetration depth, we see these curves. You may see the physicists and the radiation oncologists often talking about these kinds of curves in different conferences or lectures. I want to make sure that you understand how these work as well. So this is modeling how much charged particles are happening when we aim a beam in water. And as we get deeper into the water, we have less and less particles. But we see here, there's 4 different lines. What's the difference between these lines? The difference is the energy of the beam that was used. So this is a key concept of it. The penetration depth depends on the energy that you're using. Generally, a higher energy leads to more penetration depth. The way I like to think about it is if I shot a bullet, very high energy, it's going to speed through and get to the other side. But if I do a slow ball, it's more likely to kind of go slowly and not make it through to the other end. Same with X-ray beams. You can see that higher energy beams will penetrate deeper. They won't have as much dose in the beginning. They'll reach their peak dose a little bit deeper into the tissue, and then the tail will also go deeper into the tissue. And now suddenly this may make sense why sometimes you'll see prescribed different megavoltage energy beams where we use higher energy beams to reach deeper tumors. Another important thing I want to point out here is that these curves look pretty different when I'm comparing X-ray beams versus electrons. We can see with electrons, when it's at the beginning at 0 centimeters, it's at 80 to 90% of the prescription dose. Whereas an X-ray beam in the very beginning at 0, it's only at 20 to 30% of the prescription dose. So what this means is that if I want to treat something that's superficial, that's on the skin, either I need to consider using electrons, which will have that superficial higher energy, or I need to add something that's going to create more depth for the dose to build up so that I can have a higher dose with my photons by the time it reaches the skin. And that's called a bolus. In addition to the particle type and radiation energy, the penetration depth also depends on the composition and the density of the tissue or the medium that it's going through, whether that's water or air or bone. And how energy deposits depends on the density.
Lauren also asks, are you explaining the Dmax of different energies?
Yes, here. Where you see the peak, this is where the beam will maximally deposit its energy. So if I well, this comes down to physics, because when they're doing their QA, they're choosing what points to measure at different depths. And so if a physicist wanted to know what's going to be the dose here, and they measure this to be 60 gray at 12 centimeters, well, that means that somewhere earlier on, it was getting 100 gray. So it's helpful to know where the dose is peaking, especially with 3D conformal treatment, where you may not be using many angles for your beams. For IMRT, though, we're going to be shooting beams from many different angles. And so we'll sort of see that this helps average out the smoothness of the dose distribution.
Another question, does the use of IMRT minimize the use of electrons and give better tumor control?
The use of IMRT is with photons. Sometimes we'll still use electrons as part of the treatment. For instance, for breast cancer, if you want to give a boost to the lumpectomy cavity, sometimes they'll use electrons. But generally, yes, IMRT, we're talking about X-ray beams. And studies have shown that IMRT does lead to better tumor control across a few different disease sites where we've done the specific comparisons. Other scenarios, IMRT may have similar tumor control to 3D conformal, but it has better toxicity profile. And sometimes that's important because it means the patient's more likely to get through treatment. And regardless, we want to minimize the toxicities, especially those late toxicities, which will be permanent for the patient. So how does radiation interact with matter? I'm going to focus on photons, because it was a perfect segue, but with IMRT, we're going to be really focusing on photons for this course. And it's important to know how photons can interact with matter. So in this case, we have a photon, which is represented by my little squiggly line. And there are different things that can happen when it reaches an atom. One is it can excite an electron, and then eventually that electron returns to its normal state and emits a photon. This is called the photoelectric effect. This happens with lower energy photons at the keV range. This is how X-rays work and CT scans. For higher energy photons, we have something called the Compton effect, where the photon is high enough energy that it can actually release an electron from its bound state, so that the electron goes shooting off, and also the photon is deflected, and so the photon has lost some energy, but it's going to continue going along. And this happens in the megavoltage range. So the Compton effect, super important for IMRT. And then lastly, pair production, which happens only at much higher ranges, but you can produce an electron and a counterpart, a positron. And this is kind of illustrating that when we're using X-rays, maybe light, this is why in X-rays we don't see anything, because it's not visible spectrum.
Hey, Ben.
So I
don't
talked
know-
about the photoelectric effect. Oh, go
I'm
ahead.
sorry to interrupt. I don't know if it was just me, but your audio cut out just for a little bit. If you don't mind going back to the last slide and just repeating a little bit of that last part.
Oh, sure. So here, I just wanted to point out that there's a spectrum of energies. In radiation treatment, we are talking about X-rays, the X-ray energy spectrum. There are other lower energies where we would get to visible light, and then even lower, we would get to microwaves and then radio waves. But when a patient's wondering, like, oh, why can't I see the X-rays that we're shooting? It's because they're outside of this visible spectrum. Thanks. So I mentioned that these three different effects that can happen with X-rays: the photoelectric effect, the Compton effect, and pair production. And the energy that we use influences which one is more likely to happen. The other thing that matters is the density or the composition of the material. So there's something called Z, which I'm going to go in the next slide. But you can see that if I'm using a, let's say, 100 kilovoltage photon, if my Z is greater than 20, I'm going to be getting the photoelectric effect. If my Z is less than 20, I'm going to be getting the Compton effect. Once I get up to 6 MV over here, now almost across any Z, I'm getting the Compton effect. So that's why for IMRT treatment, we're really talking about the Compton effect. And then if you were to get into higher energy, like 15 megavoltage or 18 megavoltage, now we're starting to see that, man, for certain Zs, I'm doing pair production, and for low Zs, I'm doing Compton. So the key point is that the photon energy and the composition both matter for what effect is going to happen. Remember that each person is made of matter at the atomic level. So beginning with atoms, molecules, form together. Cells are comprised of many, many molecules, which then form tissue, and tissue to organs and organ systems, and this weird looking thing, I think it's a human. So we have an organism, or a human. It's comprised of atoms and molecules. When we do a CT scan, we get some information about the composition of the matter. So why are there different colors in the image? Why is some this white? Why is some of it black? Why is some of it gray? So it comes down to the atoms that matter is made of. I talked about Z. Z is the number of protons in the atoms. Remember the periodic table. If you look there, you'll see, for instance, oxygen has an atomic number of 8, or Z of 8. And so if you have Z protons, the atom naturally exists with also Z electrons. And so knowing that these have different parts of the body are comprised of atoms with different Z, how does this finally get applied? So calcium helps comprise bones. Calcium has a high Z, a Z of 20. And so here, if I'm using 100 kV energy or 0.1 MV, now I can see, okay, this was a high Z. So mostly it's going to be the photoelectric effect that happens. Air has a low Z. There's not much in air. And so even using the same energy, 100 kV, I see that, wow, I'm no longer getting the photoelectric effect. In this case, the Compton effect is dominant. And so when we do a CT scan, we're only going to see stuff where the photoelectric effect is happening. So that's why for our bone that's interacting with that photon, it's going to attenuate, and we'll see that. Whereas the air, without that interaction, there's no attenuation, and it looks black. And then there's a spectrum in the middle that's gray. Water is medium. And so hopefully this helps you understand at the basic level why when you do your scan, you're seeing gray or white or black. It has to do with the energy of the beam that you're using and the Z of the material that it's passing through.
I have a question from Putting Away. If you use IMRT treatment plan, do you use highest or lowest dose rate?
That's a good question. There, I guess it depends. I don't think we use the highest dose rate, and I also don't think we use the lowest dose rate.
I know for SBRTs,
Mhm.
we'll go a higher dose rate, but generally we do a 600 dose rate for like regular IMRT plans.
Mhm. Yeah, that's right. Thanks, Whitney. The only times I think that it's really important to use a lower dose rate is when you're doing total body radiation. When you're irradiating a large volume of the lungs and you want to reduce a chance for developing pneumonitis. So how does all of this go together? Well, we got a scan. Our physicist is doing calculations, or the computer has already incorporated this into its system, where it knows that the energy that we're using matters, it knows that the Z matters, and using the information from the scan is going to be able to predict what effects are happening. It's going to model the radiation dose with the beam. That model is going to show up like a dose map with isodose lines. And then from this dose map, we're going to know what's likely to happen in the body. And we think about the therapeutic ratio, we think about tumor control probability, we think about the normal tissue complication rate. And all of this starts with your work as an RTT. So everything that you do with making sure that that scan is as good quality as it can be is going to affect the treatment planning. It's going to affect the contouring. And it's going to affect the treatment that the patient gets. So we have a Zoom poll. Here's the question. The dose of radiation that's received in the body depends on the density of tissues seen on the CT simulation scans. This is because A, the density of the tissue affects the beam depth. B, the density of the tissue affects the energy of the beam. C, the density of the tissues affects the absorption of the beam by the tissues. Or D, the density of the tissues affects whether charged or uncharged particle interactions occur. So I've just launched the poll. And so I'm specifically asking what affects the dose of radiation. This is tricky, but if you get this, you're on the right track. So I see we have about we have about 100 participants who have filled out the poll. Go ahead and take maybe 10 more minutes. And I know we're running a little bit over time. Today's the first session, so we wanted to just give a little bit more time for that introduction. But this is great. We'll give 5 more seconds. 4, 3, 2, 1. Okay. Whitney, do you see that? So it looks like 70% said C, and C was the correct answer. So the density of tissue affects the absorption of the beam by the tissues. So lastly, radiobiology. Now that we know exactly how much dose is happening, how does radiation actually kill the tumors? So the dose has reached the atoms, and radiation biology or radiobiology is a science that helps us study what's happening after absorption of energy from ionizing radiation. We've talked about cancer cells grow and divide faster than most normal cells. And then the other thing that's very important is that cancer cells are not as capable of recovering after treatment as normal and healthy cells. These two things are like the most important things about radiobiology for cancer. I've talked about ionizing radiation. This is when we are using high energy photons or when we're using electrons. And remember that ionizing radiation leads to damage of the DNA inside cells, and that these ruptures prevent cancer cells from growing and dividing, causing them to die. Remember the cell cycle, which has the S phase when we're synthesizing DNA, the G2 phase, which is a growth phase, the M phase, which is mitosis, where the cell is dividing and splitting from one cell into 2 cells, and the G1 phase, where a new cell is growing. And this shows roughly the length of time that a cell spends in each cycle. Some cells have much longer G1 phases. So this isn't a universal truth, but in general, you see that the M phase is the shortest, sometimes only 1 hour. And then G1 and the S phases are longer. When is a cell most sensitive to DNA damage? It's most sensitive to DNA damage during the M phase and the G2 phase. And this is a little bit intuitive. I'll explain quickly that when our cell is dividing, it's exposing its DNA. It's like its shields are down, and now we're ready to damage the DNA. So that's why radiation works really well in the M phase. Similarly, in the G2 phase, it's like getting ready for that. It tends to be more sensitive. In the G1 phase, though, the cell is not thinking about dividing at all. It has its shields up. It's going to be resistant to radiation if it's in that phase. And in the S phase, the cell has duplicated its chromosomes. So it went from 2N to 4N. And now there's a nice template, a homologous chromosome. So if DNA damage happens to one chromosome, it's easy for the cell to fix that by using the duplicate chromosome as a template to help heal. So that's why the S phase is also resistant to radiation damage. What's happening when radiation happens? Here's a timeline. And you can see there's this immediate response on the order of 10 to the negative 15 seconds. So that's a millisecond. And there's water radiolysis, which forms free radicals. Water radiolysis, this is where we have water molecules. Remember, our body is mostly composed of water. So when radiation hits water, it forms free radicals, which can then damage DNA. And this is happening all in less than a second. And then we have an early response where a couple things could happen. Could either have no repair of that damage, which then has a lethal effect and then can lead to cell death or necrosis. Or we may have defective repair. Like I said, cancer cells are not as capable of repairing DNA damage. So if it doesn't heal correctly, that can also lead to a lethal effect and cell death. Or it could lead to mutations. Or lastly, it could lead to programmed cell death, which is called apoptosis. If there's correct repair, then the cell survives. And this is what we hope our normal cells are doing, that even though we're introducing small amounts of DNA damage, they're recovering and they're repairing with each between each fraction of radiation that we give. And then there's a late response, which can happen days later. So we start to see death happening days later, or apoptosis happening days later of the cell. Years later, we can start to have other things, and generations later, these mutations may accumulate. And this is why radiation has a risk of forming a second cancer, or in some cases, mutations can be passed on to other generations. Cell damage can be described as sublethal or lethal. So here, this would be lethal, leading to death. Sublethal, maybe it can be repaired. And we use something called the linear quadratic model to describe cell survival. The final effect of radiation will depend on what type of radiation and the rate that it was administered, and the cell population depends on what cycle the cell is. So we'll get into this. There's another term called alpha beta. And I know this is a lot of information, so stick with me. Alpha beta, I want you to think of it as an adjective, like a color. So I say, oh, that's a blue chair, or that's a red chair. In cancer, we use alpha beta to describe how a cell responds differently to damage. So I could say something has an alpha beta of 10, or something has an alpha beta of 3. Alpha beta has an alpha component, which is how a cell is having direct cell death after radiation. So damage caused to the cell that cannot be repaired. And the beta component corresponds to indirect cell death, meaning how often the cell dies, not due to direct damage, but due to an accumulation of sublethal damage that's no longer possible to repair. So if I have a cell that if I blow on it and it just dies, that has a very high alpha component. My radiation just caused direct cell death. It was not able to repair any of the damage that I caused. And so the alpha component is going to be very high. So it's going to have a high alpha beta ratio. If I have a kind of cell that is really good at repairing small amounts of damage, I may have to accumulate multiple sublethal damage to cause cell death. So this would be something that has a high beta component. And so this would have a low alpha beta ratio. The factors that influence how a cell responds to radiation, I've mentioned, and you hopefully all are familiar, but when we give radiation, we're prescribing different doses. We're saying how much dose to give per day, or how much to give per fraction, how many fractions to give, and also what time course we want to do this, so whether it's a daily or twice daily. And the alpha beta ratio is very important for when the radiation oncologist is thinking about, okay, how much dose am I going to give? How much dose per fraction am I going to give? What's my overall prescription going to be? So you may have wondered, why am we treating some cancers to 50 gray? Why are we doing some to 70 gray? Why are we doing some to 45? Why are we doing some in 2 gray fractions? Why are we doing some in 5 gray fractions? So a lot of this has to do with the alpha beta ratio of that particular kind of tumor. You'll have this slide for your reference. I think the main thing I want to say is just that a high alpha beta ratio is 10, a low alpha beta ratio is 3. A lot of times our healthy tissue we think has a low alpha beta ratio, and then things that are more sensitive to radiation in the acute phase we think of as having a high alpha beta ratio. So some examples of high alpha beta ratios is squamous cell carcinoma of the head and neck or of the cervix. Examples of low alpha beta ratios would be things like breast cancer or prostate cancer, melanoma, or sarcomas. And this influences the dose fractionation that we choose for treatments. And when we're considering how a cell is, or how tissue is responding to radiation, in radiobiology, we think of 4 R's: repair, redistribution, reoxygenation, and repopulation. And if you can understand what these 4 R's mean, you can understand almost everything about a prescription and why the radiation oncologist has chosen that prescription. So here's our next Zoom poll. We'll try to go through these quickly to maybe finish within 10 minutes. So here's a question. Which effect describes why normal tissue are more resistant to multiple treatments than cancer cells? Is it due to repair? Is it due to redistribution, reoxygenation, or repopulation? Okay, and if you're not sure, just go ahead and take a guess. We'll give 5 more seconds. 4, 3, 2, 1. Okay, great. The majority showed repair, and repair is correct. So when we damage a cell, It's either going to be able to repair that damage or not. If it does not repair the damage, then I'll show you. It gets hurt and it doesn't get better. And then the next day we give treatment, it gets hurt, it doesn't get better. It gets hurt, doesn't get better. If something is good at repairing damage, though, it's going to get hurt, but then it's going to heal itself. And so we don't have as much death that's happening over time. And so this is one big difference between late responding tissues or early responding tissues. Next question. Treatment of tumor cells on different days improves efficacy against tumor cells, although it prolongs the treatment time. So why is it that even though we're doing a longer treatment time, we might have better efficacy against the tumor cells? Is it due to repair? Is it due to redistribution, reoxygenation, or repopulation? Okay, this one's tricky. Go ahead and take 5 more seconds. 4, 3, 2, 1. Okay. So some of you are smart. The answer is not repair, because that was the answer to the last question. So process of elimination, but is it redistribution, reoxygenation, or repopulation? So, I can see why I can see why those answers may have been chosen. In this case, the answer we're looking for is redistribution. And why is this? Well, a cell is going through a cell cycle. On one day when I do a treatment, some cells might be in the S phase, or they might be in the G1 phase, and those are resistant to radiation. So that radiation treatment I did may not be very effective on that day. But then if I do treatment again, maybe a couple hours later or a day later, that cell's had a chance to progress through the cell cycle, and maybe it's in the G2 or M phase the next time I do the treatment. So then that treatment's going to have more efficacy. And the tumor is comprised of, billions and billions of cells. And so every time we do a treatment, some are going to be in the M phase and G2 phase, and that's great, but not all of them. So we keep doing multiple treatments, hoping that we increase our chance that eventually we're getting some of those cells, hitting them when they're in their G2 or their M phase. It's a random distribution, but by dividing the treatment into different days, we increase the chance of eventually treating all the cells in sensitive phases.
Hitma Lynn, she asked, how many hours do I need to separate a patient to give radiation treatment twice a day? What types of patients do you give twice a day?
Oh, great question. So this goes into repair, because the most important thing is I don't want to cause too much toxicity to the patient by being over-aggressive. So it takes on average 6 hours minimum for healthy tissues to repair. So this is why when we do twice a day treatments, we wait at least 6 hours, because we want there to be a chance for the healthy tissues to repair. The main reason that we would do twice a day radiation is when we want to give a low dose each time to be kind of more gentle with our radiation treatment. Or if we want to try to get in more fractions in a shorter amount of time to decrease the length of the radiation total treatment. In modern days, The main cancer that you'll see twice a day treatment where we're trying to cure is small cell lung cancer. And then the other times where you'll see twice a day treatment is when we're doing reirradiation and trying to be really careful about not damaging the normal tissues too much. So giving a low dose each time, waiting enough time for the normal tissue to repair before giving the second dose. Great question, though. Okay, next key point. Why can hyperthermia treatment help improve the damaging effect against cells? So you may have heard of hyperthermia as something that can be used in radiation treatment. Well, what's one of those reasons? Is it related to repair? Is it related to redistribution, reoxygenation, or repopulation? Okay, give 5 more seconds. 4, 3, 2, 1. Okay, so most of you got this correct. So the answer is reoxygenation. Hyperthermia has a couple effects, but one of its effects is it's increasing blood flow to the area. And, your blood delivers oxygen, and water molecules have oxygen, H2O. And so the oxygen is very important in order for free radicals to develop. The actual molecular interactions that happen is a bit complicated, but ultimately we need oxygen molecules there for electron to interact with and form a free radical, which will ultimately cause the DNA damage. So without oxygen, radiation doesn't work. And this is something that can be, you may see in someone that has surgery and we're treating microscopic disease, we give a higher radiation dose compared to someone who didn't have surgery and we're treating microscopic disease. A lot of times you'll see, like in the pelvis, we're treating to 45 gray and 25 fractions. But in head and neck, after a surgery, we're treating to like 60 gray. And so a lot of this has to do with reoxygenation. And if we don't have as much oxygen, we have to give a higher dose to get the same effect.
There's a couple questions. When we give up to 8 gray at once, then in palliative patients, how normal tissue repair? Will they be dead immediately?
It's a good question. Thanks for whoever brought that up. With a 1 fraction treatment, we're no longer having this ability to have redistribution because we've shot the cell once, or we shot the tumor once, and now we're not going to be doing it again. So if we're giving just 1 fraction, we need to give a dose that's strong enough that it will even hurt cells if they're in the S phase or if they're in the G1 phase. In other words, we need to give a dose that will damage the cell no matter what phase it's in. So that's why when we give a single fraction treatment, we see that we're giving a lot higher dose compared to conventional. Repair depends on the tissue. Cancer cells tend to not be good at repair. So that's why it ends up leading to more damage in the cancer cell. But there is a concern that if you give too much dose, maybe the normal tissue has a hard chance of repairing too. And so maybe there will be late-term toxicities. Oftentimes we can give higher dose at a time in the palliative setting because we're not so worried about late-term toxicities because the patient may not live long enough to actually develop those. But if we do want to give high dose at a time and we want to prevent late toxicities, then we need to be very conformal with the dose. And that's where we get into SBRT. or SRS. So the last Zoom poll question of the day, why is it dangerous to interrupt and to delay the completion of treatment? Why is it bad if the machine breaks down and now the patient hasn't gotten treatment for a month or even a week? Good. We have great participation. I'm loving this. We'll give 5 more seconds. 4, 3, 2, 1. Great. I think almost everyone got this right. So 91% said repopulation, and that's the correct answer. So what does repopulation mean? That means that the cancer cells are growing back. They're repopulating, they're populating again. And if I were to treat cancer 50% of the way, but I didn't kill all of the cells, those cells that are still there can keep growing and keep dividing. And there's actually something that happens, it's called accelerated repopulation, where not only does the cancer divide, but it starts to divide faster. It starts to accelerate its repopulation. And this is kind of scary. You may have noticed that sometimes there's a tumor that's been growing over the course of a few months on a patient, and then they get a surgery, they cut out some of it, but not all of it. And then within just a few weeks, the whole tumor grows back to the same size it was, or maybe even bigger. Why did that happen? So that's an example of accelerated repopulation, where the cancer basically gets angry. There starts to be maybe more growth factors happening at the molecular level, and the cancer will grow back faster. With any time we disturb a cancer cell, it starts to grow back faster about 21 days later. This varies according to cell type. It's most commonly seen in squamous cell carcinoma. So cervical cancer, head and neck cancer, we have to be very, very careful about accelerated repopulation. This is why it's so important, why the doctors want to finish that treatment within 50 days or so for cervical cancer. And if there's a delay, there's going to be more cells that grow back, and we may even need to consider adding extra dose to make up for that missed days, because now there's more cancer that you have to treat. So this is why it's important to finish a treatment within a certain period of time. Now, what if I have a short treatment, like something that's 10 fractions? Well, accelerated repopulation is not going to happen until at least 21 days. So if I have a 5-day delay, it actually doesn't affect it very much. So when I think of short treatments, I think that finishing that treatment on time does not matter as much. But when you have a long treatment, now you're getting past that 21-day window. Now delays in treatment are really important. In conclusion, to achieve greater depth of tumors, we need to adjust total radiation dose, the time interval between fractions to allow healthy tissues to recover, and the dose per fraction. And this is possible with different dose fractionation schemes. You've seen conventional fractionation. There's also hyperfractionation with a lower dose per fraction, but maybe given twice a day with that 6 hours in between. There's hypofractionation, where we may be giving more than 200 centigrade a day, maybe even 800 centigrade a day. We often see this in palliative treatments, where the patient may have a shorter expected survival, where it's necessary to have rapid tumor destruction. We can't sit and wait 30 days for this treatment. We have to get it done in 5 days. And maybe we're not as worried about the late-term side effects. Examples might be 30 gray in 10 fractions, 20 gray in 5 fractions, or 800 gray in 1 fraction. And as I alluded to, we're starting to learn more about using high dose per fraction for curative treatments like prostate SBRT or prostate moderate hypofractionation, breast moderate hypofractionation, or fast forward melanoma, SBRT, SRS, etc. I'll skip over accelerated fractionation, but this is just a way to get the treatment done in less time. And as I mentioned, if you delay the treatment, you may see this described as protraction, but we're allowing the tumors a chance to repopulate. To illustrate, one study found that for each day that you protract or delay, make the treatment longer, you're losing your chance of tumor control by almost 2% for head and neck and 1% for cervix. So the missed days, it adds up especially for squamous cell cancer. These are some nice links that you'll have on the slides. Good if you want to learn more about the physics of radiation. I only touched on the most important things today, but there's a lot more. This is a great series of videos. I studied these for my physics board exams, and you can get a sense of what is there to know about for physics. Other good readings for radiation biology, there's this IAEA training course, and then these distant learning courses that I found, and a textbook that is good here for those that like books. And for the rest of the course, next week, we're going to be talking about the evolution. Oh, go ahead. We'll have a chance for Q&A now, but next week we'll do the evolution of technology and radiation. We're very excited to begin this learning journey with you. Thank you for your attention. We are a team. Together, everyone achieves more, and it's such an honor to be here with you today.
Hello, dear.
Hello.
Excuse me, I have a question.
Yes.
You can send me all links via through email.
Yes, we will send you the PowerPoint slides.
Yes.
They will be on Google Drive. Google Drive is something, it's just a link on your computer. You can also get the app Google Drive on your phone. I highly recommend it for this course. It'll make it very easy to see all the materials that we send you.
Okay. Thank you.
So Ben, there have been a lot of great questions in the chat, and I know we're running a little over time, so I'm not sure that we'll get to all of them live. So we can do whatever you think is best. I've been writing them down as we go. I know some sessions in the future will address some of the questions, but we can also call some out here or try to respond offline since we're a little over time.
Yeah, can I ask one question, please, if you don't mind?
Sure.
Okay. Hello, my name is Abid. So my question is about IMRT dose modulation. The thing, if you compare IMRT with me, the dose rate modulation is IMRT is different from VMAT. So is it possible that in IMRT, the modulation is done with MLC only, not with the dose rate? Am I correct?
So IMRT, I think of as an umbrella term, and VMAT is one form of IMRT. We'll get more into, I think, your question as we talk about the evolution of radiation technology and the different forms of IMRT, and those will be led by our medical physics experts. So if it's okay, I think I'll defer your question until that session where I think they can provide a better answer.
Okay, sure. Thank you. Thank you very much.
No problem. Great. wanted to say hi to Saif and the team from Yemen. It's great to see you all. And I'm gonna, for those that are interested in staying and hearing the answers to these questions, I'm gonna try to answer as many as I can in the next 5 or 10 minutes. If you need to leave though, feel free to hop off. It was great having you today. And we'll see you next week. Okay, the first question that I see, when can we say that there's a chance for repopulation? Like the patient has stopped treatment for how long? So hopefully I answered that. After 21 days is really when I start to worry about repopulation, especially for fast-growing cells like squamous cell carcinoma. For cervical cancer, you want to try to finish with treatment within about 50 days. So the radiation oncologist will be thinking about that. If a treatment is severely delayed, if it's gone to 70 days or 80 days, they may need to give more dose to compensate for that repopulation. And we have a document about treatment delays too. So if you're interested, maybe put it in the chat. We're happy to share that in our with our presentation as well in the Google Drive. Say so, okay, we did that. Okay, what about those cases with less than 21 days of treatment? We talked about that. I don't worry so much. It's okay if there is some small delays for a short treatment. Okay. So a lot of questions about accelerated repopulation. In brain metastases, we give 3 to 5 fractions. Yes, often that's true. Is there a course to help RTTs to understand the compensation approach to achieve 56 treatment days for squamous cell carcinoma? We don't have a training course on that, but we're thinking about it. In the meantime, though, I'll share this very helpful document about managing treatment delays. It seems to be an issue in several countries. Let's see, Chi-Chi, was anyone recording the lecture? I missed most of it. Yes, we recorded this and we'll share the recording with you. I see lots of thank yous. I hope that this session met your expectations and it's helpful. I don't see any other, are there any other questions? What is the difference between adult and pediatric and 4Rs? Oof. The main thing is pediatric kids have a long time that they're going to live. So we really think about the long-term side effects, and even a kid who's less than 3 years old has much bigger risk of long-term side effects compared to a kid who's older than 3 years old. So for a lot of pediatric malignancies, we will try to avoid radiation as much as we can if they're less than 3 years old. And then for the sort of older pediatric population, we're still very careful about the volume of dose that we're giving and the dose prescribed. So you often see lower doses used in pediatric cases. It's for a reason. It's because we're worried about the toxicities. The 4Rs still apply kind of equally among kids and adults. I think that some tissues are developing and growing more. So, so normal tissue, like I said, cells get damaged when their DNA is exposed, when they're multiplying and dividing. So you may have increased acute side effects for those kinds of cells. On the other hand, kids are also very young and healthy, and they tend to be good at repairing things. So it's it's a complicated thing. Okay, send the attendance link, please. We'll put the attendance link in the chat again. So please try to fill in this attendance form. within 1 hour from now, we'll see your mark and you'll get credit. And next session, can you talk about BID treatment approaches? Sure. How do we calculate the BED? Oh, that's great. I don't have time to go into that, but send us an email and we're happy to provide more information. Our email is training@bioscontracancer.org. And wow, so many great questions. I hope you're not tired of hearing my voice. But I think we've had a great session. I think we'll conclude for today. It was great to see everyone. Thank you for joining. You know, I know it's late in some of your times and early in others, but hope everyone has a good night or a good morning. And thank you for joining.